Thank you. Open for any questions, any thoughts of any of the lectures or brief talks so far?
For Dr. Rule, during the cardiopulmonary bypass, what are some of the intra-op variables that can predict the need for mechanical support after the surgery?
Well, thank you. There are a lot of predictable variables and a lot of unpredictable variables. Very often at a tertiary referral center especially, we're referred patients specifically because they may need mechanical support afterwards. So a lot of times it's the starting right or left ventricle, how well the right or left ventricle is working. Sometimes it's the amount of time on pump, how well you've protected the heart. A lot of times the cardioplegia management can be tricky in some patients and difficult. But a lot of times it's the things that are really predictable going into the operation are really the quality of the right ventricle especially and the left ventricle as well. The left ventricle is a little more predictable than the right ventricle, and we have probably better adjuncts to protect the left ventricle. But when you come in and you have right ventricular failure coming in, it's much higher risk of needing mechanical support afterwards. A lot of times it's what the type of operation we're going to be doing. If sometimes we go in and we know the patient is very ill coming in with endocarditis, and we know we're going to have to do a double valve with a reconstructed root and things like that, and we know it's going to be a long pump run, and you can kind of predict that those patients are going to need more support afterwards.
We also do the old principle, garbage in, garbage out. If somebody is in terrible condition, go to the operating room, but we increasing appreciation to taking somebody to the operating room in an acute shock is probably going to result in coming out of the operating room in shock. That I think is probably the most likely preoperative variable that will lead to the mechanical support.
Any other questions? Go ahead.
Can you comment on the role of D-dimer in aortic dissection?
In terms of its utility, there certainly has great utility in patients with acute DVT and PE. I'm unaware of it as a. I think that it should raise the suspicion. But go ahead. Do you know?
Yeah. So its utility, I think it's good in ruling out, but definitely not ruling in. So if you have patients with low index of suspicion, then I think a D-dimer. Again, I think there's only one study to look at with a D-dimer. But from my recollection, it's good to again like the role of D-dimer and all the other. Good to rule out, but definitely not to rule in. So there is some data, but again, only in low risk.
Yeah, but I would not recommend that you use it as a if you've got somebody with a high index of suspicion, I would rule it out with imaging rather than with serologic testing.
I'm going to ask a question with Dr. Ash and Dr. McGivry about how do you all manage a combined cardiology and cardiosurgical approach for submassive PE with and a PE which comes transferred, because that's the patient we get. Somebody who we get a call about a submassive PE, there's a panic button raised, and so how do both the services kind of collaborate and manage those patients? If you can comment on that, share your experience.
That's a tricky question because there's no really right answer there, and I think really goes, it depends on the patient. So if you have persistent RV dysfunction and persistent biomarkers which are elevated, then I think at least our practice here and most centers would be to either consider half dose or low dose thrombolytics or ecos based thrombolytics. I think that, of course, making sure the patient does not have any contraindication for thrombolytics.
When would you get Dr. McGivney a call? When would you give him a call?
So I think one of the great advancements in the treatment of certainly submassive and massive PEs has been the role of the multidisciplinary team, and that these so-called PERT teams, pulmonary embolism response teams, having cardiology, pulmonology, cardiac surgery, hematology involved at some level. Intensive care, of course, team is very, very important, because there are a lot of different ways now that you can tailor the therapy for patients with acute massive and submassive PEs, whether it's thrombolytics, catheter-directed thrombolytics, ultrasound devices, using different kinds of vortex catheters to suck the clot out, to going in and doing surgical pulmonary embolectomy. So I think all hands on deck for patients with submassive and certainly massive PEs.
Any other questions from anybody? Okay, great. Thank Dr. Rasrol, Dr. Thomas McGivney, and Dr. Ash for this thing. Thank you all.